Good morning. Good morning, everybody. Today we have a very interesting topic. It's related to the medical breakthrough. And when we talk about medical breakthrough, it's not only about medication, it's about everything that is a breakthrough in the healthcare system. So you have the innovators that bring solutions. Mainly here we're talking pharma companies, devices, equipments. You have the diagnosis who get the problem and diagnose it. And then you have the medical care system, the providers, like the institutions, the hospitals. And all of that are covered by a healthcare system. So the healthcare system has to be well equipped to really cater and nurse the existing innovations. With this panel, we have a very rich panel here. We're going to discuss some of these aspects. For example, we're going to talk about the healthcare system. We will talk about the entrance, how, for example, drugs are entering the market. And we're going to talk about other elements that are important, like go-to-market. How can an innovator able to enter the market? What are the barriers? And what can we do to shorten the period from innovation to the market? So I would like to start first with Andrew to talk a little bit on the healthcare system from the general perspective. Andrew?
Sure, well, thank you very much. So I think what we're kind of getting at here is the preparedness and adaptability and readiness of kind of hospitals and systems and the healthcare system, if you like, to adopt emerging approaches and technologies. And I think so. Unfortunately, like all great questions, there isn't a simple answer to that. So, for example, it's very dependent on exactly what you're talking about. Innovation comes in a vast range of things. So, as we were saying, it might be a new pharmaceutical product, it might be a new medical gadget, it might be a new monitoring system, it might be a new way of working or a new educational paradigm. And in particular, when you're looking at kind of different ecosystems, so we've heard a lot about the NHS, for example, as one, but that contrasts markedly with both here in the Middle East and also sub-Saharan Africa and other less developed systems. So I think the robustness of the system to accepting change is very patchy. So in the in the kind of Western developed Europe and so on, we're pretty used to it. Embracing new pharmaceutical products, for example, we kind of get on board. That's a well-worn track. We're used to kind of clinical trials. We're used to developing an evidence base. We're used to kind of seeing, who they work in. Can we extend that into other patient groups and stuff? I think we're pretty okay at that. And to be honest, in terms of rolling that out into other environments, I think most systems are okay at embracing that. I think it's useful for the developed countries to do the hard yards in terms of safety and initial drug testing and so on. I think that's pretty important to do that within a well-controlled regulatory framework. I think in terms of health tech, one of the things that I've seen in the past in less developed environments is that it depends what the tech is again, but if, for example, if the tech is quite mechanical or it's sophisticated, it requires, stable IT connections and stable power and, high quality biomedical people to maintain it, those things can be very difficult to embrace in resource poor environments. I think it's very subject specific. One of the things that I think can be rolled out most effectively is the way we work. And one of my kind of passions is about kind of reliable delivery of care. There was a super interesting talk yesterday where we talked about kind of health 1.0 and 2.0 and 3 and 4, right? Funnily enough, I have very similar conversations with my students and things over the years in the sense that, now, most of the time, we have the ability to diagnose what's going on, and we often, usually, have some kind of effective treatments. And the challenge, in a way, is delivering those things reliably. So it's around this kind of implementation science. And I think that stuff, is not particularly resource dependent.
Thank you. The other thing about the breakthrough is the healthcare priorities. So, for example, in countries where the standard of care is low, maybe people wouldn't care about certain diseases if it's not mortal. So we cannot imagine a country, for example, with the poverty level is very high, maybe to care about innovation as much as they care about primary care, which is the basics of the care. This is a very important topic, and we talk about fairness, and if we ignore the standard of care and we go talk to people about certain innovation, as a healthcare provider, we're talking nonsense, right? So with this, I like Bren to elaborate about this factor, and also being in technology, maybe you can touch base a little bit about how technology can help in this domain. Thank you.
Yeah, absolutely. So innovation in healthcare, I don't think it's specific to innovation just in how we diagnose things, but it's also in how we apply and practice, how do we do diagnostics in primary care as well. So you're talking about lesser developed countries or developing countries. Innovation is the ideal way to actually expand primary care into those countries, especially into rural areas where it's not easily accessible. I've been to many developing countries in Africa and South Asia, and what I've learned is that there are times when families don't have a meal to eat, but every single member in the families from about 10 years and above have access to a mobile cell phone, predominantly a smart cell phone. Right? So if we could use these type of easily accessible technologies to deliver primary care, that's where I think a big bang for the innovation in healthcare can be. It doesn't have to be only in new drug development or in new ways of treating, but even in the primary care space. Access to technology and the continuing lessening cost of technology in developing countries is an opportunity for expanding primary care.
Thank you. Another topic is the go-to-market. Because if you got the innovator to find something and you cannot reach the market on the right time, this is also an issue. So breakthrough is not only to discover, but to make it available for the public and for people. With that, I would like Andre to talk to us about how difficult it is for an innovator, and he is one of them, by the way, how difficult it is for an innovator to go to the market, and whether certain markets are more adaptive than others, and what are the characteristics of each. A difficult question?
Yeah, it's a big one.
Yeah.
My background is in pharmaceuticals, so now I'm doing tech, and it's the point of entry is kind of the same. So we're dealing with, from a pharma business, everybody knows it's the clinical trials. It's go through a lot of, in some countries, especially emerging, some politics and the special interest you have to deal with. And I thought I skipped that going into tech, a little bit naive. So as for our perspective, we're launching in Africa right now, and data is so well documented, there's no side effects, we don't touch the patient, we just take a scan and we get a diagnosis, and how difficult can it be? But we're dealing again with special interests. So once we enter, for example, DRC, Cameroon, there are some local professors, oncologists, they feel left out, so they want to have validated data, they want to have their kind of say in it. So you always deal with the human nature of egos, politics, and I think it's very difficult to avoid. I could kind of wish we could AI the whole thing, so I could just supply the documents. Within a couple of minutes, I'm done. And I think we'll get there. And I'm strongly lobbying for we get there. Or else we keep the whole system alive. I think that's what we're dealing with. In some African countries, they refer to the British model. Some refer to the French model because they have the French system. So I don't think at this point it's difficult to avoid the politics of the game. And there are always special interests. And I think that's a bottleneck for new technology rolling out very fast. From Scandinavia, where I'm at, they are seriously looking at to AI the process, basically closing that department, what we call FDA of the local countries. If we have all the clinical data, documentation, all validated, if that could be AI'd and you can get your marketing authorization, I mean, we're talking about minutes instead of a year, right? So I think that's really the bottleneck. That there are special interests that are involved and governmental policies that are slow. One of the hard points, I think, during the COVID years, it taught us that FDA is not really working for us. They're working for the pharma industry, right? I know it's a bad thing to say, but that's the reality. If we can just kind of get that out of the way, then the world will look different. But at this point, we're dealing with a small company. We're looking at local representatives that can take us through the process, and it's very difficult to avoid. I think that's the main bottleneck: special interest, politics, to a certain level, corruption, which is more or less formalized. It's a tough one. It's a big subject.
Thank you. I'm going to elaborate a little bit about one specific element that André spoke about, which is related to medicine. Because medicine is a major solution for healthcare, right? So, for example, if a breakthrough drug is being discovered in the US or in Europe, because these are the two major drug innovation, in addition, of course, to Japan, Australia, and some other countries. China now is in the game, Switzerland, France. But let's say Europe in general and the US. If a drug is being discovered, it means it's after 10 years of an average of 10 years of research, phase 1 till phase 3 and 4. If you want to bring it to the Middle East, sometimes it takes 3 to 4 years. And why is that? Because I want to check the documentation. I mean, you can check the documentation today in a couple of seconds. Why do you need 3 years? There are laws now that it says if it's registered in the US and in Europe, within 3 months it can enter the country. Of course, you have to put regulations that applies on all countries. You cannot make one that applies only on the European innovation, because maybe this one is more trusted. But you should put certain laws and regulations that enhance the reach to your market, to your patients. And of course, this sometimes comes at a cost, because the earlier you bring the medication, the costly it is. Because as you know, pharma companies charge prime prices in the beginning because they want to make up all their research cost, right? So this is something very important that sometimes we as authorities ignore or take our time maybe to reduce the cost because it can affect their budget. So sometimes there is medical breakthrough, it's not part of the Social Security budget. So what we do, we delay, unintentionally, we delay the introduction to the drug or to the solutions to the people. Luckily, maybe in this part of the world, it's not happening, but in a lot of countries, in many places around the world, people have no access to the right solutions because of the either wrong regulations, slow regulations, or because of budget. So with that, I want to move to another topic, which is very exciting, and we are all afraid about. We spoke about the breakthrough in healthcare, and the major breakthrough that is happening right now is AI, right? Some people are saying there is no more job for doctors because of AI. For example, for radiologists, some people say no need for radiologists anymore. We know in AI everywhere, no need for lawyers, right? For engineers, 4. And in the medical breakthrough, AI is a big question mark. What type of solutions AI is bringing? I'd like to start with you, Andre. Tell us your story about AI.
Well, I'm repeating myself a bit. I would wish that as they're phasing out human intervention in this, and as AI is taking over a lot of the processes, I would wish that we could push it into the government and get documentation and approvals done. Of course, everybody knows, and there's a warnings, like Elon Musk is warning about it, that if we let the AI run wild, that eventually we'll just be sitting on the sideline. I don't think we'll get that far, but I do wish that there's a positive side to it, that we can speed up the process so we get the product to the patient much faster. We eliminate the special interests, and we eliminate the slow political processes. Of course, at the end of the day, somebody's got to pay for it. So, and the state budgets and the insurance budgets, they're not going to be AI'd overnight. So it'll be interesting. I think everything moves very quickly. It's almost month by month. At the end of the day, we'll see. We'll see where it gets. But it is interesting, and it will fast track a lot of the processes, especially in terms of patients, to get faster to the treatments. Then the question is, would the treatments be available? So another big question. It's difficult.
Bren, can you please?
Yeah, so I've been in tech for the last 20 years. I've only been in healthcare for the last 7 years. And I've been really grateful to have developed and exited about half a dozen companies and have a pretty good portfolio of innovative tech companies that I'm sitting on now. And I actually, yes, there is a threat with AI, but I don't think we're focusing in the wrong area, I think, right? Because we need to be mindful of the misuse of AI, right? However, AI can truly democratize healthcare, since we're in healthcare, but also other matters globally, right? Like, for example, Canada, I'm from Canada. Canada is the second largest country by landmass. 90% of the population sits within 20% of the southern border, which is the border with the US, okay? 90% of the indigenous population sits in the northern territories. No doctor wants to go there, right? Every doctor in the indigenous territories, just so happens, is newly immigrated East Indian doctors. Because for them to practice, continue to practice to be a medical doctor, they cannot get a job in developed cities. So they have to go work there, right? And I think with AI and expansion of internet infrastructure and more powerful mobile devices, we can democratize healthcare.
Andrew?
Sure, thanks. I mean, I think part of the challenge here is that the application of, well, for a start, we heard earlier that the definition of AI is, or at least it's used pretty loosely, so we're not all talking about quite the same thing, is number one. And the second is, the potential scope of application is so vast. It's a little bit like saying, well, what would you use a computer for? And there's the famous IBM quote, wasn't it? Or maybe we need 6 of them, in the whole country or something. And so actually, we're really, there's almost a failure of the imagination at the moment in terms of, what are the potential roles for AI, and I'll perhaps share some of my ideas, as a physician on how that might help us and our patients. I mean, I think I'm not quite sure what the scope of it is specifically with regard to this, acceleration of the technology breakthrough pathway. I mean, it was really interesting to hear Andre talking about, the kind of politics and vested interests and so on interfering with development. But even without that, certainly for a lot of, kind of engineering-based technologies, and I think in pharma, there is genuinely a significant amount of time that's required with the way we do things at the moment. I mean, we saw extraordinary acceleration around the kind of COVID vaccine stuff, where a lot of these timescales were compressed, and of course, a major part of that was, that we basically shortcutted, all the kind of trial work that you would normally do. You'd normally be waiting for, kind of safety data and stuff for some period of time, which is kind of a delay that is very difficult to get around that. So that, it does take a significant amount of time to get these technologies to market. 10 years is not unusual at all. In terms of, what we might expect for roles for AI in the workplace, I think that's pretty extensive. So, for example, we've been talking, I don't know, for at least 60 or more years about how difficult it is for clinicians to keep on top of the evidence base. So I can sit in the clinic with a patient who's got, various different ongoing chronic medical problems, and they're facing, kind of major liver surgery. And, for me to try and, understand that patient's concerns, kind of be up to speed with, what the evidence is around, how we should optimize that patient, what their risks are, and so on. That's a pretty big ask to be able to do that. And, but that's the sort of place where our AI will be pretty helpful. So, either in advance or during the consultation, we can be processing that data, and then I can have that represented to me, and then myself and the patient can have a discussion about what that information means, what it means to them as an individual, how it might affect the choices they make, and so on. So that's just in terms of decision support. There's obviously some areas where, like dermatology, radiology, where I think, there are some very serious questions that need to be asked, because these computers are pretty reliable at identifying stuff. For those of us in, slightly more practical disciplines, it's going to be a little while before AI is intubating a patient or putting them on ECMO or something. So I think I'm safe until the end of my my career. I think we've hinted about big data, and this big, and then it's big, and there's the kind of stuff like NHS cancer databases and stuff, which are obviously enormous, but on a much smaller level. So in my world of anesthesia, for example, we are now starting to look at quote-unquote AI, certainly algorithmic-based analysis of multiple vital signs during surgery and various indicators so that can, for example, predict how the patient is going to behave in some time in the future. And therefore, we can potentially intervene and prevent that. And I suspect We'll see much more of that. We'll see much more of the way, kind of analysis of patterns, and probably some kind of closed loop type intervention. I mean, we've had closed loop discussions for a very long time, but I think, that is probably going to start to gain traction soon. So that would be a few thoughts from me about the AI piece.
Thank you. We're going to move to the last topic before we open the door for questions and discussions. I want to ask the audience to raise their hand. I'm going to ask a question because here we're talking about access, but I will be asking you a question and I'd like to see your hands. If you are on a railway and the train is coming and there is two ways. On one way, there is one guy standing in the middle of the railway. On the other side, there are 5 people. And you have the option either to move it right or left. Who would move it to the one person? Who would move it to the 5? Can you raise your hand? Can you raise? Just raise your hand who would move it to the 5. Who would move it to the 1? One person? So here, most of you would move it to 1 because you put number as your criteria of access, okay? You want to save more lives. If I give you more data and I say, the 5 people are all above 90, and this guy is 30 years old and has kids and family to raise, what would you do? Right. Can you move your hand? Who would move it right? Who would move it to the 5 now? So I have more hands to the 5. And that's what authorities, they deal with every day. During COVID, they decided on age, right? They decided on age. They said, people who are older get first, right? And many people debated that the same way with the train, right? Because the data we have at that time said access to drug should come first with age. And the same way happens every day with authorities when they're dealing with breakthrough solutions in healthcare. And this topic is very debatable. What should we get first? If we have people still dying from malaria, should we worry about rheumatoid arthritis? If half of the population is HCV, should we worry about cancer even? If we're going to treat them and they're going to die anyway, I heard it from many authorities, they're going to die anyway, give them placebo. If half of the population is have AIDS, infected, do we have to treat them for migraine? So these are the big questions. If I have to treat 20% of the premature babies, who should we give them? If 10 are born and I can only give life to 2, to whom should I give? So these are big topics, big questions that are the major barrier for breakthrough medication. And I like to give 2 minutes for each of the panelists to talk about that and give their opinion, and then we open the floor for discussion and questions. Please, Andre?
If it's 5 politicians, then it's easy. That's an easy choice. No, I'm joking. No, in Scandinavia, we have it already. It's a fact. Like, in terms of oncology that I'm involved in, they do prioritize certain age, what stage of cancer, etc. So if there's a limited operating room and limited doctor capacity, they make a choice. And it's a discretionary choice. There's no set of laws. It's an ethical question, and I'm glad I'm not in that position. But it's already happening on a daily basis. And it's all a matter of budget, right? Healthcare it's energy and money, and at the end of the day, you have to prioritize. I don't know how to solve that at all. So I'm going to pass that one on.
Bren, do you think technology can sort this out?
So I'll talk about mental health because that's where my focus has been in the last 7 years. And before I got into it and coming from tech, we looked at a lot of data points, right? So there is currently more than 1 billion adults worldwide who have been clinically diagnosed with mental health disorders. So mental health disorders are disorders such as depression, or whether that be major depression or treatment-resistant depression, or various types of depressions, PTSD, post-traumatic syndrome disorder, addiction, anxiety, things of that nature. The second data point that we looked at is there are no root cause solutions for it, right? Currently, what Big Pharma has made available to the world as of now, or to date now, is managing the symptoms. And they're managing the symptoms through prescriptions that essentially works by suppressing your central nervous system. So that doesn't actually allow the person to live to their full capability or live like their true self. So we looked at, okay, what does that actually mean? And of course, you know, everybody understands this immediate impact to immediate family, friends, children, or if it's children, parents, and so forth. But we looked at it from the perspective of what does that mean to global economy? So based on the 1.8 billion or whatever, over 1 billion adults that were diagnosed with mental health disorders, the economic impact is in excess of $2 trillion, and that's just in the Western world, right? So less than 50% of the world's population represents $2 trillion loss to the global economy. So, and this is the reason I got involved in mental health, plus also because I lost my little brother to mental health. That's where I started, and I started looking at it and realized how big this problem is. So there's many things that are affecting it, and another very important key point in that is we are now prescribing these central nervous systems suppressing prescriptive drugs to younger and younger populations, right? In North America, they are now prescribing SSRI and SNRI-based prescriptions to children as young as 5 years old. So what does that mean for 20 years out?
Andrew, 2 minutes.
Right. Okay. So I think we've heard some interesting points. I mean, so clearly this business about kind of rationing, for want of a better word, and can technology help us with that? I think Andre already he made the key point that primarily this is really about ethics, and to some extent about economics and politics. I mean, I'll say one thing. I mean, as a clinician, actually we've been making these decisions all the time, and we'll continue to do so on a case-by-case basis. And actually, right at the sharp end, it's often not as difficult as it might seem, because typically you're presented with very binary kind of choices. Well, do I admit this patient who's horribly shocked and is 95, or do I admit this other patient who benefits from ICU? So generally it's not quite so difficult at the sharp end. I think it's much more difficult at this kind of sort of macro level, if you like, where you're trying to decide about things like drug licensing. You're trying to decide, what are our health priorities? And I think, this is where you've got to start looking at where do you get the best bang for your buck at sort of, government taxation, insurers type level. And this preventive piece is super important. And we've heard about, mental health in children, developing good habits, stuff like that, because that's where you're really getting, kind of maximum mileage. And I'm sure many of you will have seen or come across these statistics, like I think originally from North America, where they showed that crazy numbers like 90% of the health expenditure on the average person was in the last couple of days of their life, as you strive to keep them alive. So I think I don't feel like the technology is going to be particularly helpful in this space, although it may perhaps have a role in helping us to figure out, the evidence, maybe.
Thank you. I think the only today, the only answer to this for authorities, for providers, is the health economic outcome research, HEOR. This is the only tool that authorities in developed markets are using to embrace breakthrough, because they analyze what is the cost of the treatment, the whole treatment, versus the economic benefit that you spoke about it right now. And if it overcomes, then they will pay for it. If it doesn't, either they force the providers to reduce prices, or they simply don't introduce, because it's economically is not feasible. And data and technology would help in further analyzing the HEOR, particularly in markets or in countries where data doesn't, exist, properly exist. They can extrapolate through AI. So now there is a big hope that HEOR would be adopted in many countries around the world through the technology and through AI. We are left with 9.30 seconds for questions. Please, if you have any questions you would like to address, please go ahead.
Thank you for the interesting discussion. My name is Tabinda, and I've got a nursing background. Medical breakthroughs are my interest also. I've helped a lot of organizations to do this. I worked with Lucas. If Dr. Andrew is aware of Lucas, that's his compression machine, which is a great medical breakthrough for nurses because we don't break our backs compressing patients' chests. Recently, I do work in Saudi Arabia also, and recently, a few years back, they brought in Sophia. Sophia is a human-like robot who interacts with people. My questions to the panels are, does this kind of robots, or will this kind of robots have that human touch? Or if it's replaced with doctors and nurses, will these kind of robotic breakthroughs have that empathy and sympathy towards patients?
Who would like to take this?
I'll take that one because I'm actually investor in a company that's working on that. Again, it's all about perspective, right? So you got to put that into context. If you look at Japan, for example, seniors just don't have access to people to talk to, right? That's just a matter of fact. If you look at the MENA region and even in the Indian subcontinent, depends on the topic, it's very taboo. There's a lot of stigma around many of these topics that we're talking about in healthcare. So this is where I think those robots can help, right? So you may not want to talk about something because it's a taboo or a stigma in the region or in the culture or even at home in the family. But you may feel less judged or less prejudiced when you're feel like you're being less judged when you're speaking to a robot, right? And I think it's not the empathy that you're speaking of is not a function of the robot, it's a function of the developers who are developing the robot, right? So if they can't understand the mission with which that they're doing this for, then I think we could actually get there. But I think this can actually be very helpful to people.
Can I ask you a question for the audience? If you need a surgery and you get the two options, robotic surgery or pure classic human surgery, what would you take? Can you raise your hands? Can I see? I would like to see the majority. Would you go for robotic surgery or human surgery? What you would go? Who says robotic? Please raise your hands. And who says human surgery? Can somebody volunteer to say why robotic? Please, come to the microphone. Why robotic?
So first to clarify, there is no robot that currently does surgeries on its own, and there is never going to be a situation where robots do it on their own.
Great.
What the robotic surgery currently does is certain maneuvers that's never going to be interpreted by humans. So for example, a robot can move its arm in 8 different dimensions, which humans cannot. So if you want to have a really an amazing stitch, which improves your recovery time and everything, robotic surgery is the way to go. And again, this is maybe in the future, in the next 20 years or so, my answer would be different if there is a Sophia that operates on me on its own without any surgeon in there, but as of right now, or in the next 10 years, that's never going to happen.
Thank you. And who says human? Who would like to say why human, please?
Hi, everyone. So basically, I was trained in neurosurgery as a registrar last time. As a doctor, when we want to become a surgeon, you need to go through a very long road, at least 10 years. And the reason is not because of the surgical skill that you are needed, but also the critical decision. So as a neurosurgery, last time when we need to operate or clip an aneurysm, we had difficulties when we need to make an impactful decision at the table to decide whether this patient should continue to live or should sacrifice some part of the brain. So the decision of approach will actually impact the patient, and you require empathy and understanding of the patient. So I think that's the reason why human, if I were going to go through an operation, I will still choose a human to operate instead of robots, because they'll make a human touch decision. Thanks.
Thank you. Although some we don't trust robotic, but when we travel, autopilot is doing the job, right? It's even worse. Okay, any more questions? Please.
Hi there, my name's Dr. Mia. I would just like to say I wanted to choose a third option, which was a robot supervised by a human surgeon. And what we find with a lot of digital technologies is that humans and patients and users always want the combination, so the technology is supervised by the human. So I think when we get scared about robots and humans robots taking over the world, and also we maybe should be scared about humans taking over the world, is that as long as we know that there's human supervision and human ethics involved in every company, in every country, in every innovation, we don't have to worry. It's just that that regulation has to be in place. So I was just interested what your thoughts are on creating regulation worldwide around AI and robotics that use AI to be able to quell all these fears about us sort of being replaced by robots or AI, or robots that use AI and machine learning.
I think I have aviation background, so it's like when we fly, right? Most airplanes, they fly from basically wheels up till touchdown, and pilots are just monitoring the systems. I think it's kind of the same approach. Let the airplane fly, because it actually flies better than the pilot. But you just want to have the pilot there in case there's a lightning strike, right? And in Scandinavia, I know that some surgeons already perform distant surgery. Like we have one abdominal surgeon who, on a monthly basis, does surgery pediatric in New York. He actually does it out of Copenhagen. So they do program the robot to go in and do the performance, but they monitor the system and can always intervene. It's already going. So whether regulations should be involved or not, I'm really, and I like to keep the politicians out of it, and I think the surgeons are capable of making that decision if they just evaluate the technology right. So it's already happening. It's been going on for a while, and I think it's good. It's excellent that you have a specialist that doesn't have to travel 10 hours by plane, jet lag, being tired on operating, and the cost of it is just stupid. So if that surgeon can be in Copenhagen University Hospital and on a screens monitor and have a robot perform the surgery on a baby that needs it now, it's ideal. It's perfect. And I think there'll be much more out of it. I think Sophia kind of got angry at some point, didn't she? She did. She was provoked and got really, yeah, we don't want that. Don't want an angry doctor robot.
I think we're living in a hybrid model right now, directly or indirectly. In most of the services, there is a lot of robotic part. And I agree with you, the human intervention is essential. It provides us more trust, and we feel more safe, I think, with human intervention. But as the other mentioned, the technology and the robotic is providing precision that sometimes human cannot reach, which is amazing. The last question that maybe, before we close, is related to genomics. Maybe we want to talk about quickly with Andrew. We're out of time? Okay, all right. We're done on time anyway. Thank you. Thank you so much.
It's a narrow escape.
Thank you. Thank you, gentlemen.